second edition book second first quality
copy
IAP first edition copy waiting room
waiting room. മൊത്തം എനിക്ക് 33 പേരായി. അതെല്ലാം കൂട്ടിട്ടാ, എല്ലാരും കൂട്ടിട്ടോ.
വെയിറ്റിംഗ് റൂമിൽ ചേർത്തിയോ? വെയിറ്റിംഗ് റൂമിലുള്ള ആൾക്കാരെ
ഇല്ല കേറിയില്ല. അല്ല ജോയിൻ ചെയ്യിപ്പിക്കട്ടെ.
എട്ടായി, നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാല്ലേ?
Madam, Leda, can you hear me?
Zulfi? Digit service start.
We can start. About 50 people. That's more than enough.
Okay, madam.
Am I audible?
Yes.
Okay. So, good evening, all. Welcome to the PG teaching program. Our focus this 2021 is on activities that will help the postgraduates, and we are really very happy to see that our dreams are coming true. Today, the topic is rheumatic heart disease, which is presented by Dr. Amal Sasidharan, postgraduate student from Government Medical College, Thrissur. All the best to you, Amal. The teachers, Dr.Zulfikar Ahamed, Head of Department of Pediatric Cardiology, KIMS Hospital, Trivandrum. Sir has been heading the Pediatric Cardiology Unit at the Government Medical College, Trivandrum before his retirement. Hearty welcome to you, sir. We Thrissur IAPians are very privileged that you are with us today. Dr. Anandakrishan, yes, sir. Dr. Anandakrishan, National Vice President, South Zone 2020, is the moderator for the session. Warm welcome to Dr. Anandakrishan. Also welcome to Srijit, Secretary of our association. Last month, we were very happy to be engaged in very fruitful activities. IAP Thrissur observed the World Cancer Day on February 4th with Teaching Institutes Jubilee and Mother holding presentation, and yesterday on International Child Cancer Day, a world-class photography exhibition was arranged by Amala Medical College. The proceeds will go for aid for children's cancer. Online activity was also well appreciated with Dr. Badira, Assistant Professor of Oncology at Tata Memorial, who gave an excellent overview of evolution of pediatric cancer over the last 2 decades. IAP also stood in solidarity with IMA. We know the unfortunate problem of mixopathy. So few of us members joined the IMA members to reiterate their stand against the same in the one-day strike, and we voiced our stand against our mixopathy last Wednesday. We are very happy to state that the first human milk bank was inaugurated last week at Jubilee, and also it was started at General Hospital at Ernakulam. IAP Thrissur has promised all help for this noble initiative. On 25th of coming month, we shall be holding the infection immunization series talk by a national speaker. So do members join in for all this, give your suggestions on how we can make this human milk bank a success. Any suggestions from you all will be helpful. So I conclude by welcoming you all. I can see a lot of senior members, Parvati Madam, Komlavali Madam, Moni Sir, Lata Madam. Welcome to you all. And let us start the discussion without much delay. Over to Ananda Keshwan, sir.
Very good evening. Respected President Dr. Sasidharan, Secretary Dr. Sayyid, the great teacher Dr. Zulfikar, sir. I think I can say the father of a pediatric cardiology in Kerala or India, Dr. Zulfikar, sir. Parvati Madam, Komlavali Madam, other colleagues from different medical colleges and students. Today we have a great teacher with a great topic. When we are studying rheumatic heart disease, is a very great problem. We study all types of rheumatic heart disease, MR, AR, and all this complicated problem like that. Similarly, we used to say congenital heart disease, VST, and other heart complicated VST, means ACM syndrome and everything. But dramatically, I think all nowadays we are not seeing a very complicated VST because all are under surgery very early, so we are not seeing any ACM syndrome only. Now the VST, RHD, the most common acute heart disease, now replaced by Kawasaki disease and viral myocard. I think Zulfikar also agree with me. So the changing scenario, I think it is due to the development of treatment, the standard of living, and everything create a lot of changes, especially in case of rheumatic heart disease. I think we old people are very expert in rheumatic heart disease because of we saw so many cases. But new generation are not seeing that much of cases. That is true. And another thing is the changing pattern and changing diagnostic criteria of rheumatic fever. Because now they have created separate criteria for developing countries and developing countries. And also, I don't know, there is so many anomaly, I think, because we cannot diagnose nowadays rheumatic fever without echocardiogram. But it is not there in the criteria. But we have never seen erythema marginatum or even subcutaneous nodule very commonly. But they are included in the major criteria like that. I think there is some revision again. I think so. To talk all these things, we have an excellent speaker, and I think Zulfikar sir not need any introduction to this crowd because Zulfikar sir was a regular speaker of all state CME, South India CME conducting issue. And Zulfikar sir was head of the Department of Pediatric Cardiology from Medical College Trivandrum. Later he joined KIMS and also Gokulam Medical College, and also he is also a clinical professor of pediatric cardiology in CDC Trivandrum. And also he contributed to many chapters, including my textbook of IAP textbook of pediatric cardiology, and also he was the chairperson of the IAP Pediatric Cardiology chapter Kerala. And he's a great clinician, teacher, academician, and also a very good some language. Different types of language and what everything very good. So over to Dr. Zulfikar sir, and also all the best to my student Dr. Amal. Over to Zulfikar sir. Unmute.
Amal?
Yes, sir. Shall we?
Sir, want to say anything? No, Amal started, sir.
Okay.
So good afternoon to all. respected faculties, and my dear friends. Today I'll be presenting a case. So my case is Tansi, 11-year-old boy. He was admitted on 19/1/2021. The informant is mother and seems to be reliable. The presenting complaints were he had fever for 1 week, breathlessness for 4 days, and facial puffiness for 4 days.
Can you be a little slow? Amal, can you go back to the previous slide? Yeah, 11-year-old, fever. You can go slow. We have no problem. We will have fever for 1 week. Then breathlessness, again 4 days. And facial puffiness is again 4 days. Okay, right. Go ahead.
So coming to a history of presenting complaint.
Yeah.
Tansi, the 11-year-old boy who is a known case of an acquired heart disease on medication, which was diagnosed 8 years ago, which was diagnosed at 8 years of age, presented to us with history of fever for 1 week. And he started to have fever 1 week back, which was a low-grade fever and intermittent type. It was not associated with any diurnal variation. The fever was not associated with any upper respiratory tract complaints or GI symptoms. And the fever was controlled with paracetamol, subsiding with it, but persisting over the next few days. And 3 days after the onset of fever, he started to experience breathlessness in the form of rapid breathing and chest indrawing. The breathlessness was more at night, especially after he goes to sleep. A typical episode would be like he'll be minimally dyspneic when he's going to sleep. Then he would wake up from his sleep due to breathlessness after a few hours and would sit up in his bed unable to lie down. The breathlessness would subside in a few hours and he would go back to his sleep with his head and raised on pillows. And these episodes of breathlessness were associated with cough, which was having scanty expectoration and mild chest pain. The cough was intermittent and present usually only when he was dyspneic, and it got relieved when the dyspnea subsided initially. The mother has noticed that during these episodes of breathlessness, he was also febrile. He had also complaints of the chest pain, which is a mild type of chest pain, and it is of dull character, and it's localized into the central chest without any radiation or any relation. There was no relation to inspiration, or it was not associated with any sweating also. He has no history of any post-acute syncope or vomiting, no history of any hemoptysis or any audible wheezing. The duration of severity of this breathlessness and cough increased over the next 2 days, such that each episode took longer to subside. By the end of week, he started to have dyspnea even during daytime while doing his routine activities, and later even at rest. But these episodes of chest pain were not, these episodes of dyspnea were not associated with chest pain like the initial ones. That's when the parents decided to bring him to our hospital. Mother had also noticed that he was having facial puffiness in addition to the above symptoms during the last 3 days, just present throughout the day. And she has, on detailed questioning, she also says that he has been having edema on both his legs for the past few days. And she doesn't remember when we started earlier, the edema, the pedal edema or the facial edema. There's no history of any cyanosis or palpitations, no history of any syncopal attacks, no history of seizures or hemoptysis.
Please little slow. No history of cyanosis, no history of palpitation.
No history of any
Copy. Okay, hemoptysis mentioned. Yeah, go ahead. Nocturia.
No history of polyuria, nocturia, oliguria, or dysuria. No history of any joint pain with rashes in the recent period.
Okay. Okay, we'll go to the. Okay, right now let's stop at this particular point. So this is a known case of as you said, an acquired heart disease, which was diagnosed at the age of 8 years. Now he is 11, so 3 years have passed. This is in the present history. So a known case of an acquired heart disease presenting with breathlessness, which means which side of the heart, Amal, is affected?
The left side of the heart, sir.
Left side of the heart, and later followed
Left
by
atrium.
Whatever, left side of the heart. Then you have the facial puffiness and edema, which came little later, which means you have a right side.
Right side also.
You have both a left side as well as a right side cardiac problem of recent onset, who is known to have an acquired heart disease. That is the basic premise of this particular patient or a child. Because you started by saying that I am presenting a case of this thing. It is always better to be a little more personal say as a child or a boy, be a little more personal. So I think this case thing should be removed from our, education presentation. So we have a boy who has known to have an acquired heart disease, who has recent onset of fever with, of course, a right-sided, a left-sided, and a right-sided symptom. So based on that history, you know the diagnosis anyway, and we all know the diagnosis rheumatic, whatever said and done. What are the possibilities? In a broad canvas, what are the possibilities you will think of in the beginning?
Okay. The first diagnosis is probably rheumatic heart disease because it's an endemic condition.
Whatever
Then
said and
next,
done, most common acquired heart disease, even now, especially chronic heart disease, is a rheumatic heart disease, rheumatic valvular heart disease with either aortic or mitral becoming decompensated, right? That is one possibility due to various reasons that we will discuss later. Second possibility.
Second, it may be infective endocarditis on a already existing heart disease.
Okay, super. You may be an infective endocarditis on a already existing rheumatic valvular heart disease. The first would have been probably either a recurrence or a mechanical problem. We will discuss that later. Right, good. Then.
It may be an undiagnosed congenital heart disease which may be presenting late, like a VSD with an AR.
Okay. Correct, super. That is another possibility because just because he has known to have an acquired heart disease, we don't know. So this could still be a congenital heart disease, and this time probably had a infective endocarditis, fever, etc. Or as you said, development of either an arrhythmia or an AR, which can precipitate and got into a heart failure. Very good. One possibility always you should think of a infective endocarditis on a congenital heart disease. Super. Then
other conditions like mitral valve prolapse with AMR.
You are thinking of a mitral valve prolapse with MR again becoming worse either due to an infective endocarditis or due to a continuous mechanical problem. Okay, that's it. One particular area you are still blind. You have an
already existing heart disease which was worsened by anemia or
which one? Yeah, okay, that comes later. But when Ananda Keshavan started his introduction, he said that rheumatic heart disease is equally challenged by other acquired heart disease. One particular heart disease he mentioned. Not Kawasaki. You don't expect an 8-year-old child to have Kawasaki and then suddenly goes into a biventricular failure at 11 years. Something else he mentioned. He said dilated cardiomyopathy, acquired heart disease. One very important condition is a dilated cardiomyopathy. See, suppose this child was known to have a dilated cardiomyopathy. He may be put on multiple drugs and child will be relatively stable. He will be on regular follow-up. And currently, the survival of a dilated cardiomyopathy in childhood is much better than when we were postgraduates some 20-30 years ago. So this child right now would have gone into an acute decompensated heart failure because of either because of fever or lack of drugs or something else. So DCM also has to be thought of. So the point I would like to say, Amal, is that you have done very well in your differential diagnosis. Especially, I'm very happy that in spite of knowing well that this is an acquired heart disease, you should think of a congenital heart disease which has got an infective endocarditis as a complication. And I also agree that MVP can become worse suddenly because of infective endocarditis and of course a recordal rupture, and dilated cardiomyopathy has to be also be thought of. So you should say that I think because you are already committed that there is an acquired heart disease, I should say first possibility would be RHD recurrence, second possibility RHD infective endocarditis, third possibility would be dilated cardiomyopathy, followed by congenital heart disease with infective endocarditis. These are the situations we should think of. So whenever you ask further questions into this person or examine this person, these possibilities have to be thought of in a boy. Then, and we know that he had a left heart disease and then followed by a right heart symptom. And one very important symptom you mentioned, going to sleep and becoming breathless after a few hours, right? So Amal, can you hear me?
Yes, sir. Yes,
Amal?
sir.
Yeah. What is that called?
Paroxysmal nocturnal dyspnea.
Nocturnal dyspnea, where a person with a left heart disease will go to sleep after 2 or 3 hours. He will become dyspneic, and whatever he does, whatever you have done. Your description has been a typical, a textbook description of the symptom, and that is a very important symptom. What does that imply, Amal? What is the physiological
It
implication?
implies that the dyspnea is of cardiac origin, and it implies that there is underlying left heart failure,
Correct.
increase in left
Absolutely.
atrial pressure.
Yeah, correct. So this points to a very clear-cut diagnosis of a left heart disease. Very, very clear disease, so which could be due to RHD, very infected endocarditis. You can have a dilated cardiomyopathy. Everything is possible for this particular patient, PND. Okay, Said Bakri is here. Said
Yes,
Bakri.
sir. Yes,
Yeah.
sir.
You are from Kerala or outside Kerala?
It's from Kerala. Thrissur.
Kerala. Which part of Kerala?
Thrissur, Malappuram.
Malappuram. Okay. Sayed, can you tell me how does a person, this child has an already existing left heart disease that we have to presume. How does he develop PND? What are the mechanisms? How would you have to trace from the left heart disease going to sleep and then becoming dyspneic or PND, developing PND. How will you explain the PND? Physiological terms.
While going to sleep because of the autonomic system, this pooling of blood in the lung results in the exacerbation of the results in pulmonary congestion, which worsens the dyspnea.
No, let's say this. We suppose this patient is having a severe mitral valve disease. He has a left heart disease. He goes to sleep. What happens?
So when he goes to sleep, there will be the reabsorption of fluids from his veins, especially lower limb veins, to the circulation, and this would slowly leak out into his lungs.
Veins are a part
from interstitial fluid, from this edema fluid back into the circulation.
Very clear, because there are so many people hearing you, so they should not get confused. So he goes to sleep, and sleep is around for 2 hours. So during that 2 hours, what happens? That is what you are telling me.
There is resorption of fluid from the interstitium back into a circulation.
From where? Interstitium.
Interstitium back into.
Not from the veins. No. So this patient is having a left heart disease. There is a fluid accumulation in the body. That fluid is in the interstitium, and that will get redistributed into the. They will enter the intravascular compartment. And once in the intravascular compartment, because he lies down, the venous return will be increased or decreased?
Venous return will be increased.
So more of blood will go to the right side, which will definitely go to the left side, and whatever, right? So what happens? What happens then? So exercise. So fluid enters the intravascular compartment, that goes to the right side, which goes to the lung. It comes back to the LA, right? It comes back to the LA. During that process, what pressure increases?
The left ventricular pressure would rise, which would reflect an increase in the left atrium.
Left ventricle has a systolic pressure or a diastolic pressure. Which pressure will increase?
Diastolic pressure.
Okay. So what is left ventricular end diastolic pressure is equal to which atrial pressure? Left atrial pressure, right?
Left atrial pressure.
Okay. Which are behind the left atrium? 4 things are there behind the left atrium.
The pulmonary veins.
So
pulmonary artery.
No. Let's say 4 pulmonary veins. No, there are no 4 pulmonary arteries. So there are 4 pulmonary veins are behind the LA, and there is no valve. So if there is an elevated pressure inside the left atrium, that pressure will be transmitted to the pulmonary veins, right? And this patient is already having a pulmonary venous hypertension, what we call as a pulmonary congestion during our MBBS days. But you have already become a postgraduate, so you should say the pulmonary venous hypertension increases. Already he has a pulmonary venous hypertension. He has a disease, left heart disease. So generally what happens is that if pulmonary venous hypertension goes up to around 20 millimeter of mercury, normal pulmonary venous pressure is less than 9 millimeter of mercury. If it goes beyond 15 millimeter, you will have dyspnea on exertion. And if it goes beyond 20 millimeter of mercury, you will have what you call as an interstitial edema. And that interstitial edema will present as a paroxysmal nocturnal dyspnea. So lying down itself, say, is a factor. Lying down increases the venous return. Second point, going to sleep will cause redistribution of the interstitial fluid content into the intravascular compartment, which will worsen the situation. Any other factor, Samiha? Samiha is there?
Decrease sympathetic activity.
Correct, because when person goes to sleep, there is a reduction in the sympathetic drive, because that is very important to maintain the cardiac output. Why? Cardiac output is stroke volume into heart rate. So sympathetic drive may be important for increasing contractility, increasing the heart rate. So that is very less. So that is another additional factor. Very good. Any other factor which you can say possibly? There is a
Transient nocturnal arrhythmias.
Arrhythmias is possibility. Then there is a feeling that nightmare sometimes can precipitate this paroxysmal nocturnal dyspnea. But ultimately, the most important single point is that you should say in the examination or real life, what happens is that the person with the left heart disease has already pulmonary venous hypertension because he is dyspneic. Now, then what happens is that there is an increased venous return plus a redistribution of fluid from the interstitium into the systemic veins, which will go to the right side and then to the lung, which worsens the pulmonary venous hypertension, causes interstitial edema. Suppose the interstitial edema goes into the alveoli, we call it as acute pulmonary edema. So actually, PND is one step away from acute pulmonary edema. So the importance of PND are two types. One, that it indicates a definite left heart disease. Even orthopnea can be due to asthma, but PND cannot be due to anything other than left heart disease. Second, it is only a very few steps to developing a life-threatening acute pulmonary edema. So that is the most important symptom this person has, rapid breathing, etc. Then you had some chest pain, Amal. He had some central chest pain, which was non-anginal. What do you think could be the possible or reason for that chest pain?
So it may be a pericarditis due to RHD initially.
Not RHD.
Rheumatic
activity. Reactivation. So reactivation, rheumatic reactivation with carditis can produce a pericarditis, which can cause a chest pain. That is one possibility. Any other possibility? Suppose you have suppose it's an adult, not this type, suppose he is an adult with a chronic rheumatic heart disease. What could be the reason for chest pain other than this pericarditis?
Severe MR can cause
MR cannot cause chest pain. Very unlikely.
So AR.
AR can produce chest pain. Agree? Then suppose they develop an acute chest pain on the left side or right side in an adult with an irregular heart. You can have a pulmonary thromboembolism, which is very unusual in pediatrics. Why? Because they do not have basically atrial fibrillation. Very unlikely. I have seen only one child below 12 years who had an atrial fibrillation in rheumatic valvular heart disease. So that is another possibility you have to think of. So chest pain is there. No syncope, no hemoptysis, no wheezing, no palpitation. Palpitation is also not present. Okay. And the syncope is also not present during this episode and cyanosis. And then he had a facial puffiness and edema, which indicates a right heart disease. Okay. So basically, a non-acquired heart disease with acute decompensation, with fever, with both right heart symptoms as well as left heart symptoms. And very importantly, what you call as a PND, very strikingly evident PND. Now you go to the past medical.
Coming to a past medical history.
This history we are now keeping RHD, with reactivation, RHD with infected endocarditis, DCM with acute decompensated heart failure, and also other conditions also. Okay, go ahead.
Due to past medical history,
Ah.
the child was otherwise normal till 3 years back when he had been admitted for complaints of fever, which lasted for a week and accompanied by joint pain for 3 days. The fever was initially low grade and responsive to paracetamol, and it was an intermittent type, which later became high grade after 3 days once the myalgia set in. There were also complaints of getting up from sleep and being restless during the night, along with coughing.
Okay.
The child was brought to a hospital and admitted and started on IV antibiotics. Around 1 week after admission, child started to have pain over left ankle along with swelling. The pain and swelling were more during the morning hours when the child would wake up from sleep and would have to hop towards the toilet because he would not be able to keep his leg down. The pain decreased on medication but still persisted once the medication was off. Gradually, the pain worsened over the week and he would not even move his feet and had to be carried to a toilet. Then he started to have pain over his right elbow joint. The pain in ankle joint persisted with the same intensity even when he had pain over his elbow joint. Over the next week, he had pain over multiple joints, bilateral knee joints and small joints of hand in an additive fashion. The pain in his ankle had started to decrease when multiple joints had began to get involved. After about 3 weeks of hospital stay, they requested to be discharged due to some personal reasons and were asked to review in a week. The child was February at the time of discharge and was on oral antibiotics. During review, the child was noted to be dyspneic with elevated JVP and was admitted in PICU. The mother doesn't recall history of sore throat before this entire episode. There were no history of any skin rash. From PICU, he was diagnosed to have acute rheumatic fever and started on IV Lasix and hydrocortisone, and child dramatically improved. He was shifted out after 3 days of ICU stay on oral Lasix and Vicelon. Later, the Lasix was stopped after 2 weeks and Vicelon was tapered over a course of 6 weeks and aspirin was added. Child was put on erythromycin prophylaxis, and in view of echo findings, a consultation at SCT Trivandrum was taken in the following month, and child was started on enalapril and advised surgery at 18 years of age. As currently, the child was asymptomatic during the time of consultation. For the next 8 months, he had no issues, had no episodes of dyspnea, and was going to school on his cycle, well thriving, active, and playful. He has had 1 episode of bronchopneumonia at 9 years of age and 1 episode of URTI, both requiring hospitalization with symptomatic management, but didn't require any ICU admission. But for the last 6 months, mother says that he has become easily tired when he cycles or plays, and hence he had become less active and preferred to stay indoors. And he had gained weight during this period also. No history of any nighttime breathlessness or syncopal attacks or palpitation during this last 6 months. And they had stopped for coming for follow-up in these last few months because of the COVID issues, and had stopped taking their medication for the last 2 months.
Okay, that is your past. Past is over?
Yes, sir.
Okay, so this child, as I understand it, this child had an episode of fever with joint involvement, very dramatic, initially very subtle, but later on dramatic joint involvements with respiratory symptoms, cardiac symptoms, and was diagnosed to have, heart failure, definitely history of a heart failure in the second or readmission, and was diagnosed to have acute rheumatic fever, carditis because cardiac involvement, and was put on various drugs including steroids. So naturally we had to presume that patient had a rheumatic fever with severe carditis and was treated properly and was sent on a prophylaxis of erythromycin and also enalapril. Okay, this gives us some clue to some points. Amal, what could be the reason why he is on, if suppose this is a rheumatic fever prophylaxis, why is it that this child is given erythromycin rather than penicillin? What could have been the reason?
Maybe because penicillin allergy.
He had a penicillin allergy. Very good. He's a non-documented penicillin allergic patient. That is one reason. And then practical reason in Kerala, sometimes what happens is that many times we give oral penicillin. Oral penicillins are not easily sometimes available. But what was the reason here?
So he was initially started on erythromycin because oral penicillin was not available here. But later on the review, he was changed to Capen.
Okay. I mean, so K-pen was given. Okay. What is K-pen? I have no idea.
Penicillin V.
Penicillin V. What is the other name for penicillin V? Phenoxymethyl. You should know that. Phenoxymethyl penicillin. So exam also you should not say K-pen and all. You should say penicillin V or phenoxymethyl penicillin. What is the other penicillin which is available in the market? Oral penicillin. One brand name. It's like K-pen, you should know. Everybody knows this. Pendits and all. Have you heard about Pendits? No. Yes or no?
No, sir. No, sir.
Okay, there is something called Pendit, which is actually oral penicillin G. That is the odd injectable penicillin thing, which is an oral preparation, which is called penicillin G. We always prefer phenoxymethyl penicillin over oral penicillin G. Why? Because the absorption of penicillin G is erratic on oral absorption. So of the two oral penicillins, the better penicillin would be phenoxymethyl penicillin. Now, Amal, what would be the dose given to this 8-year-old child, phenoxymethyl penicillin?
The dose of phenoxymethyl penicillin is according to the weight, less than 27 for prophylaxis, less than 27 kg, 250 mg BD, and more than 27 kg, 500 mg BD.
I see. This is from which reference?
Nelson.
No, I don't think so. You should go back today itself. Class we should go back to Nelson and see phenoxymethyl. Phenoxymethyl penicillin dose is same for any age. Any age. The difference in the dose is basically for sulfa, which we nowadays don't use. Then penicillin G, benzathine penicillin, we have a separate dose for different age group, like 27 kilogram, but not for penicillin V. Penicillin V is 250 milligram twice daily. Suppose you want to give erythromycin, what will be the dose? Say 250 milligram twice daily would be the dose. So erythromycin can be used. Sulfa used to be used. Nowadays we don't use it. And then penicillin can be used. So that is the. Now he is also put on enalapril, right? So regarding the valvular lesion, what does it tell you? I think we'll ask somebody else. Shalu has come. Shalu. So Said Bakri is the only sacrificial lamb here. Shalu is there? You have one Jewel Mary, a very fascinating name. Is a PG or a faculty? Jewel Maria is there. You can unmute if you are a postgraduate. Carol is a postgraduate or MO? I have no idea. Postgraduate. Postgraduate. Carol. See, all of you are not supporting Amal. Amal is consistently being asked to answer questions. You are not supporting. I will go back to our old Said Bakri. Bakri, you are there? Bakri, the PND fellow, PNDP, it's not there. What is happening here? Anybody other than Amal, any postgraduate other than Amal can come forward and tell from can you deduce anything from the fact that this child was offered enalapril also along with the penicillin prophylaxis. So what could be the lesion? Anybody? Aslam is there? Aslam? Samiha vanno? Tirichetiyo? Okay. Now, Amal, Samiha vanno? Samiha, we are wasting time now. Time is very precious. Time is of essence. Samiha, the child was put on enalapril with a rheumatic valvular problem. Which valve is likely to be affected? Suppose it is put on enalapril. Mitral or aortic?
Mitral valve.
Mitral
valve causing a significant cardiac failure.
Okay, mitral valve. So mitral valve involvement in rheumatic fever can be, or rheumatic heart disease can be MS or MR. So if the child is given enalapril Which is likely?
More likely MR.
More likely MR. Likely MR. Actually, there is nothing like more because enalapril is absolutely contraindicated in a stenotic lesion like a mitral stenosis. So if enalapril as a balanced vasodilator is given, it should be given to a regurgitant lesion. Theoretically, it can also be given in AR, but usually we do give enalapril in a MR. So naturally, we have to presume, this is a very important practical point from the history. You have already deduced that this is an acute rheumatic fever with carditis. Then it's a bad carditis because he had a lot of problems in the hospital, ICU stay, IV, steroids have been given. So it's a bad carditis, it would have been a very severe carditis. And the child was put on enalapril, which means the child had a significant residual mitral regurgitation with or without aortic valve regurgitation. That is a different thing, but mitral valve regurgitation is the most likely cause. Now later on, child developed a fatigue also. Amal?
Yes, sir.
He had fatigue, he had some dyspnea on exertion, but there is no palpitation. So in spite of this dyspnea, fatigue, etc., he had no palpitation. Are you surprised or not surprised, Amal?
Palpitation.
You would have expected or not expected in this patient?
If it's, palpitation takes time since for the this chambers to enlarge.
Okay, no, that's not the way. Actually, when you have a regurgitant lesions like AR or MR, exertional palpitation is very classic. You don't get an exertional palpitation in MS or aortic stenosis. So because we already think that this patient has a significant MR, we would have expected some exertional palpitation, not a paroxysmal palpitation. So I am mildly surprised that there was no palpitation. But there was some fatigue, right? The fatigue. What could be the reason for fatigue, Amal? Amal, all your colleagues have forsaken you. You will be like Jesus, you are like Jesus Christ on the mountain, saying, "Oh God, thou hast forsaken me." Last dialogue ഉണ്ട് Jesus Christന്റെ. അതുപോലെയാണ് അമൽ പറയേണ്ടിയിരിക്കുന്നത്. Oh my brothers and sisters, you have forsaken me. I am the only one answering, nobody else. Yeah, I mean, it's very tragic. Except Samiha's voice was heard in between. Shalu is there?
Yes, sir. Yes, sir.
Very good. Salu, tell me, what is the reason for fatigue in a chronic rheumatic heart disease? When will a fatigue creep in a chronic rheumatic heart? Because we think that this patient is having...
When the child is having increased exertion, maybe the cardiac output is not met by due to the mitral regurgitation, due to the increased...
No, you improve the language, then I will understand. You tell me.
In case of severe MR, when cells are severe moderate MR, during exertion, his increased needs won't be met by the reduced stroke volume.
Okay, so basically you are saying that the stroke volume is less and the heart cannot make more on exertion, right?
Yes, sir.
Okay, so it is called a low fixed. There is one term called a low fixed cardiac output. Whenever you have a low and fixed cardiac output and forward stroke volume is less, you will have fatigue. So what happens in a very severe MR is that the LV pumps blood. Part of it goes to the LV, part of it goes to the aorta. So a significant amount of LV volume goes to the LA rather than going to the aorta. So forward stroke volume is reduced, and at some time later in the natural history of MR, even on exertion, the stroke volume cannot go more. So that will cause a fatigue. So you had dyspnea was there, he has fatigue is there. But Amal, except for that acute illness, he had no chest pain, no?
No, sir.
No chest pain, so no angina. So because as Amal was saying sometime earlier, the chest pain or angina can be due to an aortic valve regurgitation. So less likely to be aortic regurgitation, more likely to be a fatigue. And fatigue, you should know, is a late manifestation of MR. So which means that the person is not doing well. Any person who has got MR with the fatigue developing, you should think that he is not doing well and he probably needs a surgical intervention. That is the point I want to make. And now off medicine, probably he has gone into either decompensation or recurrence. Both are possible, because he
Yes,
was
sir.
not on medicine for the last 2 months, including penicillin. You can always have a recurrence. And recurrence is maximum during the first 5 years. Very important. I think there is a study showing that the first 5 years, the recurrence chance of medicine is 40%, 40. Then 5 to 10 years, it is around 10%, comes down. And after 15 years, the percentage is very low. So 15 years after the first attack of rheumatic fever, even if you, it's not correct to say that, I'm not giving the wrong message to you. You are 15 years from the first episode, the chance of a recurrence is much less. But the maximum chance is in the first 5 years. That is what has happened here. So this patient would have either had a recurrence, or because of this lack of medication, he went into a severe acute decompensated failure. This is called the acute decompensated failure, right? Okay, now. Yes. Hello? Anandakeshan എന്തോ പറയുന്നല്ലോ, കേട്ടില്ല.
Will you give any importance to?
I cannot hear you.
Small joint involvement
here. Amal, Dr. Anandakeshan is interested in the small joint involvement, because small joint involvement is not at all common in rheumatic fever. So how do you explain that small joint involvement? Is it possible?
It's possible in it's very rare in rheumatic heart disease, rheumatic fever to involve small joints, but in Jacob's arthropathy, small joint involvement can be seen. It's a definite indicator that there is a cardiac lesion associated.
Okay. Jacob's arthritis, but Jacob arthritis usually produces a deforming arthropathy, that is why they will produce deformities. But even otherwise, for example, sometime back in the 80s and 90s, we had done studies on 100 consecutive cases of rheumatic fever. We found that around 7 to 10% of children with a non-rheumatic fever, acute rheumatic fever, had a small joint involvement. Even very rarely spinal involvement. One or two patients had a cervical pain also with the rheumatic fever. It is rare, but it is possible to have this thing. Need not be always due to a Jacob's arthritis. I agree with you, Jacob's arthritis will produce smaller joint involvement with deformity, but need not be always. Okay, now Amal, come back to the other findings.
Coming to the natal and postnatal history, he was born as second child of third-degree consanguineous marriage. The natal history was uneventful. He was born with a birth weight of 3.3 kg, cried soon after birth. No history of any ICU admissions. No history of any feeding difficulty or succus cycle or irritable crying episodes. No history of any breath holding spells during infancy. No history of any cyanotic spells. Child was well thriving, gaining weight adequately.
Okay, we'll stop at this point. We'll go back. One I am interested in. You said feeding difficulty, succus cycle. Why? Because of we wanted to rule out a heart failure in infancy. Then you said breath holding spells or a regular spell because you wanted to rule out a congenital cyanotic heart disease. Why did you what did you ask about the history of a irritable crying episode in infancy? What is the logic in this patient or in other patients? Generally also.
In infancy period, this orthopnea can cause irritable crying
episode. Okay, sometimes. Okay, what else? Suppose you leave this child alone. You talk about another infant who has got episodes of irritable crying. What are the possibilities you will think of?
SVT.
SVT is a possibility. Good. Any congenital heart disease which can produce irritable crying episode. Very important condition. Acyanotic condition, with all pediatricians and all pediatric cardiologists should be aware of.
VST?
No, not VST. VST, when they may be irritable, but this typical irritable crying episode in the first year of life.
ABCD.
AVCD is not the answer.
Alcapa.
If they have angina, infants have angina.
Alcapa.
Infants have angina, you can have irritable crying episodes. It can be Alcapa. Another interesting thing, Amal, is that we have seen older children and even a 30-year-old lady who had been on therapy on regular prophylaxis for so-called rheumatic MR finally turned out to be having an Alcapa with LV dysfunction and MR. That is why suddenly I was interested in this irritable crying episode. Whenever in the examination people ask you causes, cardiac causes for an irritable crying episode, three things are there. One is an SVT, correct? Second is an Alcapa. Third is a cyanotic spell. Very important. Cyanotic spell also can produce an acutely irritable crying episode. Then child was well thriving, gaining weight adequately. Right. Go ahead. Next slide. Next part. Development.
Development history. Yes, development normal. All milestones were achieved in time. He's good in arithmetic and academics. Good social interactions. Immunization history. He was immunized for age. No history of any AFI. No additional vaccinations were taken. Diet history. He's an intake of 2,800 calories against a requirement of 2,100 calories, and a protein intake of 38 against a requirement of 40.
Okay. What?
Family history. No history of any cardiac.
Go back to the previous slide. Why are you interested in specifically in arithmetic? Q? You think that is a measure of a man's intelligence or what? Why particularly? Anyway, it doesn't matter. Go ahead. He is good in academics, no? So unnecessarily don't put something. Yeah, good in academics, good social interaction. Very good. Correct. Good. Next. Yeah.
Family history. No history of any cardiac disease in family. No history of any systemic illness in family. The elder sibling was treated for TB, but that was before Tansi was born.
Okay. Now go
social
back to
history. They belong to a lower.
Go back to the previous slide. Yeah. Yeah, no history of other systemic. What are the systemic illnesses? Not in the family. What are the systemic illnesses other than rheumatic fever which can produce a mitral valve disease?
Ehlers-Danlos syndrome. Connective tissue disorders.
Yes, connective tissue disorders. Then systemic
syphilis.
Syphilis. Okay. Aortic valve. Aortic roots. No, systemic illness. I am giving you a clue, highlighting the systemic part. Anybody? Shalu? Any very important?
Marfan syndrome.
Marfan syndrome. Any systemic disease which can cause with fever. Systemic, the term, there is a catch term. Systemic. Systemic lupus. Yeah, SLE, most important cardiac abnormality in SLE is a mitral valve disease. Severe MR is a possibility in a mitral valve disease. In Marfan, childhood Marfan, the most common valve involved is mitral valve, not the aortic valve. And your Ehlers-Danlos, all those things are there. But always think of an SLE, always think of a JIA also, because JIA also can produce a mitral valve illness. Because whenever we discuss rheumatic heart disease with mitral valve illness, the examiners are going to ask you about other systemic illnesses which can produce arthropathy, because all of them can produce arthropathy and valvular lesions. And the elder sibling was treated for tuberculosis before Tanzi was born. Right. Next.
Social history. They belong to a lower middle class family. The father is a daily wager, studied till 10th standard. Mother homemaker, studied till 12th standard.
Okay. Examination. Right.
Coming to examination. The child is conscious oriented but is agitated and is dyspneic. He prefers to stay in sitting position. The vitals, the pulse rate was 56 per minute, regular, normal volume, normal character, no radial or brachiofemoral delay. All pulses felt equal and bilaterally. Blood pressure was, upper limb was 100/60 and lower limb was 130/90. The respiratory rate was 48 per minute, abdominal thoracic with increased work of breathing. Temperature of 99 degree Fahrenheit. JVP was elevated, 9 centimeter above sternal angle, and SpO2 was 96% room air and 99% with oxygen.
Okay.
General examination. The child is pale. There was no icterus or cyanosis or clubbing. He had bilateral pitching pedal edema present along with facial puffiness. There is no significant lymphadenopathy.
Okay.
Head-to-foot examination. The child is obese and he is currently sweating at the time of examination.
Child is obese.
Yes, sir.
What is the weight? What is the weight of the child?
40.
This is calorie intake. Okay, you are coming to that.
Coming.
Yeah,
49 kg, sir.
How old is he? 11-year-old, right? Okay, obese.
11-year-old.
Anyway, you will come back. He's sitting.
No dysmorphic facies. Oral cavity has no caries, no features of pharyngitis, no limb anomalies, no Marfan node habitus, no neck swellings, no peripheral signs of AR, no peripheral signs of infective endocarditis, no subcutaneous nodules or rashes on face, trunk, or limb, no scrotal swellings, no pyoderma scars. Anthropometry. His height is 148. It's between the 75th and 90th centile. Weight 49, between the 90th and 97th centile. Head circumference 54 was normal. Upper segment, lower segment 0.92 was normal. BMI 23.5 in the obese range.
I see. What is the reference for this BMI? 11-year-old 23.5. Which chart? Which chart? Indian chart or whose chart? Was it a CDC chart or IOTF chart or something else? What do you usually carry? WHO. Okay. You see, it's a 23.5. Using it is obese. Okay. Anyway, right then.
Cardiovascular system.
For cardiovascular system, I want to ask you some questions. One is your heart rate, no? Heart rate, pulse rate is 56 per minute, which is, of course, will invite comment from the examiner, right? In this particular patient who is presumed to have chronic rheumatic heart disease with significant mitral valve disease, who has come with an acute decompensated heart failure, possibly due to various reasons, and has now got a pulse rate of 56 per minute. What could be the reason? What are the theoretical possibilities for a low heart rate in this? We actually expected a very fast heart rate, no? This is very much surprising. Yes, very much surprising. Why? What could be the reason?
A heart block is a common association, is common finding in a rheumatic heart disease.
I see. Heart block. Heart block is very common. What kind of heart block is common in rheumatic? What is the usual
first degree heart
block? Usually, first degree heart block, Amal, is happening where you have a prolonged PR interval. There is a one P wave, one ventricle. That rate is normal. You don't get a bradycardia in a first degree AV block. So you have to think about a second degree AV block or a third degree AV block. So you tell me the relevance of second degree AV block or prevalence of second degree AV block or a complete heart block in a chronic rheumatic heart disease. Is it likely or less likely?
If it's a severe valvular lesion,
then it has nothing to do with the severity of valvular disease. Is it less likely, very much likely?
Likely.
No, it is very unlikely. See, the third degree heart block, complete heart, never go away with an impression that complete heart block and second degree heart blocks are common in rheumatic fever or chronic rheumatic heart disease. It is not common, not at all common. The complete heart block is practically unknown. It's very important for the postgraduate to carry home this point. Complete heart block is practically unknown in this thing. And this may be one of the rare causes which we are going to see. We will see anyway the ECG. Second degree heart block can occur. Then the rate may be 56 because the atrial rate would be 112, right? So that would be okay. But that is also very rare, very rare to have a heart rate. So that is one reason. Any other reason why a child with rheumatic heart disease, not in this child, suppose a child has a chronic rheumatic heart disease with mitral valve pathology, suppose the heart rate is 56, what could be the reason? If you give this correct answer, anybody who comes with the correct answer, we shall send you, when you give a pen as a gift from Trivandrum.
root abscess, aortic root, and
Aortic root. Yeah, that is different. Correct. I'll come back to that. See, root abscess, because if you have a, that is why, Amal, rather than rheumatic fever process or rheumatic carditis, it is the infective endocarditis which can produce a complete heart block. Because your two diagnosis was like that. You had sort of a second diagnosis. What was the second diagnosis? Chronic rheumatic heart disease with infective endocarditis. Then you thought of a congenital heart disease with infective endocarditis. So you should have said that infective endocarditis can produce a complete heart block due to various mechanisms, including a root abscess. Very good. Then another possibility is that suppose you have a severe MS or a moderate to severe MS waiting for a balloon. This child will be usually put on a beta blocker, atenolol. And atenolol, as you know very well, can produce significant bradycardia. So that is the second reason for this. So very unusual to have rheumatic fever process to produce bradycardia. Infective endocarditis definitely can produce second degree or a third degree heart block. And simple sinus bradycardia can occur on beta blocker for a mitral stenosis. Then your lower limb BP of 130/90, no? That is little unusual because usually lower limb systolic BP will be definitely high, but not the lower limb. So the examiners may feel that the candidate has not examined, but I don't, I trust you. You think this is 130? You're sure?
Yes, I think so.
I think so.
Yes,
You said you did the examination.
I felt it was 130/90, just sometime back.
No, 130 fine, but 90 I am little suspicious, but okay, doesn't matter. We have to trust people. I have a fast respiratory rate, temperature is okay. JVP is elevated for 9 centimeter above the sternal angle. Okay, so definitely elevated JVP. So what will be the average right atrial pressure in this child, Amal? Can you calculate the right atrial pressure in millimeter of mercury from this value? Anybody? Louder?
14
centimeter from right atrium. 14 very good. So 14 centimeter of water or blood, which can be converted into millimeters of mercury. Very good. Who said that? What 14? Who was that? Was the PG? Anyway, so what you do is you add 5 because sternal angle is 5 centimeter away from the mid right atrium. So 9 plus 5 would be the 14 centimeter would be the right atrial mean pressure, which can be multiplied into 0.75, 3/4 of that value. So something around 10-11 millimeter of mercury, normal being 7 millimeter. So this is definitely elevated JVP. Very good. Next. So you have a normal BP, unusually a low heart rate, and he is obviously in heart failure, right heart failure, right. Next. CVS examination. Okay. That the rest is okay.
Cardiovascular system examination, inspection. The precordium appears to be normal. Apex beat is not visible. No other visible pulsations. No dilated veins. No surgical scars or swellings. Spine appears to be normal.
Okay.
Palpation. The apex beat is felt in 5th left intercostal space, 1 centimeter lateral to midclavicular line. A forceful apex confined within 1 intercostal space. No thrill. Left hair external pulsations are present without any heaving. No palpable P2, no PSC pulsations, no suprasternal pulsations. Percussion, the cardiac borders are percussed and the right border corresponds.
Any thrill elsewhere? No thrill elsewhere.
No thrill, sir.
No thrill. Okay. Then.
The cardiac borders are percussed, the right border corresponding to apex and the left behind the sternum.
Right border corresponding to apex.
Left border corresponding. Oh, sorry, sir.
Right border, yeah. Right border corresponding. Left border corresponding to the apex.
Border corresponding to
right behind the sternum. എങ്ങനെ നമുക്ക് അങ്ങനെ പറയാൻ പറ്റിയ പാൽപേഷനിലെ പിറകിലാണ് സ്റ്റേണൽ ബോർഡറിന്റെ പിറകിലാണ് ഇരിക്കുകയെന്ന് പറയാൻ പറ്റില്ലല്ലോ. അറ്റ് ദി സ്റ്റേണൽ ബോർഡർ എന്ന് പറയുന്നതല്ലേ നല്ലത്? At the left, right sternal border. Okay. Then. So as
no dullness of no dullness of pulmonary area.
Okay.
Auscultation. S1 is soft. S2 wide and variably split.
Wait a minute. Slow. S1. This is very important. No. S2 is wide and wide split.
Variably split.
Okay. Increases, changes with the respiration. So if it is split, you have to comment on P2. So what is your comment on P2? Abnormal.
P2 of normal, normal.
P2 is normal. Okay. No S3. No S4. Okay. Then
No clicks, snaps, or rubs. Soft and systolic murmur of grade 2 to 3.
No, maybe slow. No click, no snap, no rub. Is it a routine thing or you were looking for it? Among the three things, click, snap, and rub, which did you look for in this admission?
Rub can be looked because it's a reactivation. Clicks can be seen in AR.
Click can be seen in AR. I see.
Because of the rapid ejection.
No. What about snap?
Mitral stenosis appears late after 10 years. Unlikely in this admission.
He's 8-year-old and now he's 11-year-old and 3 year is there. No, so even though rather uncommon, but you can have a latent period of only 2 or 3 years in a juvenile mitral stenosis in India. So that is still possible. So snap is possible, rub is possible, but click I am not very comfortable with the click because this is very important, Amal. See, suppose you say S1 is soft, very important. That is very, I will come back to that. Then you are saying S2 is wide and variable split. Very important. The examiner will be very happy. And he will also ask about the P2, look for a PAH. Then you say no S3, no S3. Which would you stress on, S3 or S4 in this patient?
S4.
No, S3. We will come back to that. Then again, what I am telling you is that if you say no click, no snap, no rub, they will say, okay, so routinely this fellow is asking. But you specifically say, sir, there is no snap, there is no opening snap, there is no rub. Then things, it will convey to the examiner that you are thought of these possibilities, right? Similarly, what happens is that this patient is symptomatically has left heart failure, right heart failure. Do you agree with me? Yes, and one of the most important finding in a left heart failure is an LV S3. Very important. You don't expect an S4 in chronic MR, chronic AR and all. So you don't expect S4 at all in a child. So whatever you expect is an S3. So if I were in your position as a PG, I would specifically say, sir, there is no S3. Then you stop, put a full stop there, and then say no S4. Then you say no snap, no rub. Click, you can avoid. Anyway, right. അതായത് പറയുമ്പം ഹിതമായ രീതിയിൽ പറയണം എന്നുള്ളതാണ്. Okay, now go ahead.
A soft and systolic murmur of grade 2 to 3 intensity heard at apex with radiation towards axilla. Best heard with diaphragm, and another short diastolic murmur of grade 1 heard over left fourth intercostal space, heard with diaphragm while child was leaning forward.
I see. This is the fourth space. Okay. Then next is respiratory. Okay, we'll go back to this. Correct. We'll go back to this. Now, Amal, S1 is soft, right? S1 is soft.
Yes, sir.
And S2 is wide split with normal P2, no S3, no S4, no additional sound in diastole. And you have two murmurs. One is a pansystolic murmur. Another is a diastolic murmur. See, diastolic murmur can be classified into early, mid, and late. What is this murmur?
Early diastolic murmur.
That you should say, very important. See, because suppose you say this patient is having significant MR and a mid-diastolic murmur, which can be due to MS, which can be due to various reasons. But when you say early diastolic murmur, it can mean only one thing. What is that? What is that?
Murmur of AR.
So you are committing that there is an MR, significant MR, maybe a mild AR also, right? That is how you progress.
Yes,
now I want somebody to come up. Samiha undo. We have been looking for Samiha for some time. Samiha undo.
All three are there. Bakri, Samiha, and Salu
is there. Okay. Samiha, please answer my query. Are you there or not? Yes or no? That would be the first answer. You can unmute if you are there. Okay, still silence, a chilly silence for a teacher. Very sad. Shalu,
Yes, sir.
Shalu, suppose
Yes,
you
sir.
in this particular patient or any patient who has got rheumatic heart disease. If you have rheumatic heart disease, can you please
Hello.
mute other people? Other people, can you mute so that Shalu can answer my question? No, go back. If you find a mid-diastolic murmur in this particular child who has chronic rheumatic heart disease, as we suspect, what are the possible causes?
In chronic, if it's a chronic case, I will suspect mitral stenosis.
One is mitral stenosis. Very good. Then
Another possibility of a diastolic murmur is usually an aortic regurgitation, but it's usually an early
okay.
diastolic murmur.
So
Austin pin murmur in an inhalation.
no. Some who is this Shalu? Shalu,
Yes, sir.
Shalu, in chronic, I am asking you about
Okay, chronic. Okay.
murmur, a very specific murmur.
Austin pin murmur.
Austin Flynn murmur of
Austin Flynn murmur in chronic AR.
Chronic AR.
Okay. Then anything
because
else?
of relative mitral stenosis.
Yes, because of a severe MR, if you have a severe MR, there is an increased flow across a normal mitral valve or a non-stenotic mitral valve, you will get a
relative.
You can get an MDM. And this person also has come with a possibility of a reactivation carditis. So when you have reactivation carditis, there is a
Cady-Coombs murmur.
So actually, in a chronic rheumatic heart disease, there are 4 reasons why we should have a mid-diastolic murmur, but there is mainly one reason for a early diastolic murmur. So it becomes very important, Amal, to characterize the diastolic murmur, because sometimes when you have severe PAH due to chronic mitral valve disease, you can have a PR murmur. But in this patient, there is no LPH, there is no epigastric pulse, P2 is not palpable, P2 on auscultation is normal. There is absolutely no pulmonary hypertension clinically. So you don't expect an early diastolic murmur due to pulmonary regurgitation. So this early diastolic murmur has to be due to an aortic regurgitation. Now come to the final possibilities. What is your working diagnosis? What is
working diagnosis? Rheumatic heart disease.
Rheumatic heart disease. I am writing it.
Coming in reactivation.
Most likely a reactivation.
Reactivation. Severe MR.
Reactivation with carditis, right?
Reactivation with carditis.
Carditis venalo.
Yes, sir.
Then severe MR.
Mild AR.
Mild AR.
Type 2 heart block from the ECG.
Okay. How can you diagnose second degree heart block clinically?
So I wrote this after the X-ray and ECG.
So very dangerous. Suppose പരീക്ഷയ്ക്ക് പോകുന്നു, പരീക്ഷയ്ക്ക് എക്സാമിന് വരുന്നു, നിങ്ങളുടെ വാർഡിൽ കിടക്കുന്ന ഒരു പേഷ്യന്റ് ആണ്, ഇത് 2 ആഴ്ചയായിട്ട്. യു സേ ക്ലിനിക്കൽ ഡയഗ്നോസിസ് സെക്കൻഡ് ഡിഗ്രി മൊബിറ്റ്സ് ടൈപ്പ് 2 AV ബ്ലോക്ക് എന്ന് പറഞ്ഞു കഴിഞ്ഞാല് ഭയങ്കര പ്രശ്നമാവും. ആവൂല്ലേ അമൽ?
ഞാൻ ആക്ച്വലി ECG കൂടി കഴിഞ്ഞിട്ട് ഡയഗ്നോസ് വെച്ചിട്ടുണ്ടായിരുന്നു.
അത് പാടില്ലല്ലോ. നമ്മള് പാവപ്പെട്ട PGകളാവുമ്പോ നമ്മള് ക്ലിനിക്കൽ ഡയഗ്നോസിസ് ആണ് ആദ്യം പറയേണ്ടത്, അല്ലേ? എന്നിട്ട് മാത്രമല്ല MD പീഡിയാട്രിക്സിന് എനിക്ക് തോന്നുന്നില്ല ECG എക്സ്റേ ഒക്കെ വെച്ച് വളരെ ഡീറ്റെയിൽഡ് ആയിട്ട് ഡിസ്കസ് ചെയ്യുമെന്ന്. അഥവാ ഡിസ്കസ് ചെയ്താലും you can never put it as second degree Mobitz type 2 heart block. Very suicidal, I would say. We will take it away from this working diagnosis. This is a working physical diagnosis. And then in heart failure, all you can say is that probably this child may be having an AV block of some sort. That is all. So in heart failure and a history of an acute pulmonary edema, okay. Then no features of infective endocarditis. no features of pulmonary hypertension. I would put pulmonary hypertension above infective endocarditis because heart failure and PAH are the accompaniments of mitral valve disease. So when you commit that there is severe MR and mild AR, you should say whether there is PAH first. Then you should say no features of infective endocarditis last, because that is there. That has to be said, but that should be last, and never ever say second degree Mobitz type 2 AV block in the clinical diagnosis. So now I know that you are very what you call as thrilled to show me the ECG. Come on, let's have the ECG. Oh, you have the X-ray. Okay, we'll have the X-ray first. We'll take the X-ray. Okay. So comment on the X-ray. Saeed Bakri, are you remaining?
Yes, sir.
Yeah, very good. Because it is almost like Agatha Christie novel. Then there was one. ഒരാൾ മാത്രം ബാക്കിയുണ്ടാവുന്ന ഒരു അവസ്ഥ അല്ലല്ലോ എന്ന് എനിക്ക് വളരെ സന്തോഷമുണ്ട്. But Saeed, you read the ECG. Is it a good ECG, good X-ray?
It's a good X-ray with adequate exposure.
No. Is it a good X-ray or not? Is it an 11-year-old boy? Is it generally considered a good X-ray or not? Is it a well-taken X-ray or not? Fortunately, we don't have radiology colleagues. Is it an expiratory film or an inspiratory film?
Expiratory film.
It's a genuinely, I mean, expiratory film. It's not a good film. You have only 5 ribs there. You need around 7 to 8 ribs to be shown. So it's an expiratory film. It may be even a lying down film. 11-year-old child. See, 11-year-old child who cannot lie down properly because of orthopnea. We expect the child to be having a chest X-ray, PA view, an erect position, but this is expiratory film and also possibly lying down film. Anyway, it's not a good quality X-ray. But whatever you can make out from the X-ray regarding cardiomegaly, because expiratory film, you are not supposed to comment on the cardiomegaly because there may be spurious cardiomegaly. So in spite of this expiratory film, you are not getting a marked cardiomegaly. Say it's only mild cardiomegaly. So are you surprised or not surprised? You are surprised because you have severe MR and severe mild AR, combination of MR and AR. So that is definitely not expected to produce such a mild cardiomegaly. Okay. What else is there in the lung fields?
Lung fields, lower lobes, there is congestion.
Pulmonary venous hypertension. There is some pulmonary venous hypertension is there. Okay. What about the left atrium? Very important left atrium. Is there enlargement or not?
Enlargement is
almost a straightening of the heart border.
Straightening of the left heart border.
Yeah, but it's not a very good X-ray. I don't think very decent information you will get it from this X-ray. The only thing is, in spite of an expiratory film, I feel surprised that the cardiomegaly would have been much more. What I expected was from his finding, I expected a little more of cardiomegaly. Anyway, next ECG. Amal, yes, Amal, I agree with you. There is a second degree. Is it a second degree or a complete AV block? I think it's a second degree AV block.
Second degree AV block, sir.
The other P wave falling on the T wave. Otherwise,
T wave.
Okay, so it's a second degree AV block. See, tell you, Amal, I think with Anand Keshavan and all, you should make a paper out of this. Very important report. Because let me tell you, from 90 onwards, it's almost 30 years in SAT hospital, I've only seen 2 second degree AV block in children with rheumatic heart disease, right? So it is, even the second degree AV block is very rare. I think you should definitely write a report and send it to, and with Anand Keshavan there, I think it's very easy.
Very rare. Yeah.
It's very rare. I think you should report it. It is very rare. And complete heart block is extremely uncommon. Extremely means practically unknown. So RHD, reactivation carditis, severe MR, mild AR, heart failure, no PAH, and there is no infective endocarditis. It would be your final diagnosis. Okay. So
also any chamber enlargement.
Chamber enlargement? No, the point is in a P wave in lead V1. If you look at the lead V1, lead 2, what about lead 2? Can you go back to lead 2? If you go back to lead 2, P wave is neither right atrium nor left atrium. But you should remember, Ananda Keshavan, is that the ECG finding of atrial enlargement, the sensitivity is only 50%, 40 to 50%. So ECG is not a very good indicator of a left atrial or right atrial enlargement. That is one point.
Cardiovertebral left ventricle here.
Then when we go to precordial leads, can we go to precordial leads? If you go to precordial leads, what is happening is the adult pattern R by S is less than 1. And P wave in V1 also you can lock, because if it is a negative P wave, predominantly negative P wave, we would expect a left atrium, but that is also not there. Then V5, V6 and all. So it's not it is not suggestive of a significant LV volume overload, because Q waves are there in V5, V6, but they are very small. I mean, rather small, and the R waves are only 12, around not even 12, 11 or 10. So there is no LV volume overload based on the ECG. We would have expected a significant LV volume overload in this particular patient. So we expected a left atrium, which is there, not there. We expected an LV, which is not there. So it just means that ECG can be sometimes a poor indicator of chamber enlargement. But X-ray suggests that there is LA enlargement. So that is the point. Now, Amal, we have where are we now? 92. Okay, maybe 8 minutes or so. I think I will ask you very quickly, Amal, what will be your prescription? Just give me a prescription when the child goes home. What will be your full prescription? 1, 2, 3. Just give me points. That's all. What are the points?
Okay.
Mm.
Child would be sent home on aspirin, according to which time we are discharging.
Okay,
It
so
will be
you
around
are
50 mg per
actually,
kg.
So I will say it again. You will basically try tapering the steroid of length, and you must already put him on aspirin in a lower dosage, and you will tell them that you should discontinue at whatever time. Okay, that is first point. Second point.
Adequate bed rest should be.
Yeah. Bed rest should be there. Okay, rest should be there. We'll say rest is there. The parents will ask you how long, because he's a school child. Even then, right now it's a very good thing, because only online classes are there. Suppose a child was having a regular schooling, they will ask you, when will my boy go to school?
12 weeks.
Maybe after 12 weeks.
Yeah, up to total duration.
After 12 weeks.
Yeah, around
total duration of
almost
therapy.
3 months you have to be at home. But now it is very good for him because he can have an online class. Okay, right. Now third.
Then
Because
on antibiotic prophylaxis.
With rheumatic fever, carditis, heart failure, you should definitely take a good rest till heart failure controlled, and at least 8 to 12 weeks of rest at home. Good. Then third point.
Antibiotic prophylaxis.
What is it called?
Secondary prophylaxis.
Yeah, you will give a secondary prophylaxis. Preferably,
penicillin is preferred 3 weekly.
But if it is not there, we will give penicillin V, right? Penicillin V. K-pen, you said. Then fourth point.
Then he would be advised to continue his enalapril from MR.
Enalapril, because of the severe MR, has to be continued, and it also improves the heart failure. So enalapril has to be continued. Then
dietary modifications.
He's obese, no?
Yes, sir.
So you want to reduce the weight? Huh?
Yes, sir.
Okay, dietary modification to make him slim. Okay. Then, okay. It's very, very rare that pediatricians are asked to do like this now. Usually we say improve the nutrition and okay. Then any other prophylaxis we would think of
Infective endocarditis.
endocarditis prophylaxis.
Not required.
Okay, that is the point. Very good. That we will come back to that. Okay, infective endocarditis prophylaxis. Amal feels that it is not required based on the 2007 AHA guidelines. We will come back to that next. Anything else? Tapering steroid, bed rest, schooling later, secondary prophylaxis, enalapril dietary modification. And what is the current status? I mean,
Okay.
is it 2 or 3? No, 3, almost. Status.
So I'm not able to catch.
No, in NYHA classification, what is the current status?
Currently, NYHA 2.
You said he cannot. No, 2 or 1.
This is a case from 1 month back, sir. So, current situation NYHA 2.
No. When you examine that particular patient,
at that time he's in NYHA 4, sir. At trust he was having
almost 3 to 4. Okay. Right now the patient is in the ward.
No, sir. He was discharged 1 month back.
1 month back. Right now you don't know what is the status. You don't know.
Yeah.
No, sir.
Okay. Now at the time of discharge, what was the status? That's all I asked.
So NYHA grade 2.
Okay, NYHA 2. Okay. Now you tell me classification of NYHA. Let me be very clear about this. How will you classify NYHA?
There are 4 grades.
Yes,
NYHA
4
grade 1,
grades
2, 3,
class.
and 4.
It is called
Class.
grade or class?
Grade.
NYHA class.
Class. Very good. Class. Class 1, class 2, class 3, and class 4. Okay. Tell me what is 1? Yes.
1.
There is
No
limitation.
neon exertion. No
There is no
neon
limitation of
exertion.
physical.
No.
No limitation.
No dyspnea.
Yes, sir.
So no limitation of physical activity.
Yes.
There is no fatigue on ordinary activity.
Correct. Very good. Who said that? Who was that? Huh?
Said Bakri.
Okay. Very good. See, that is 2 points, Amal, you should know what is your friend told you. That is 1, ordinary activity does not produce any symptoms. So symptom does not mean dyspnea alone, Amal. There are 4 symptoms covered in NYHA. What are they?
Dyspnea, fatigability,
palpitation, and chest pain. These are the 4 points. So ordinary activity does not produce any of these symptoms. So class 2 will be
Slight limitation of ordinary activities.
Ordinary activity will produce symptoms, correct. And class 3 will be
less than ordinary activity.
Correct, less than ordinary activity. So see, ഒറ്റ വാക്കുകൊണ്ട് പണ്ട് നമ്മുടെ നാലുകുഴി പാല് കൊണ്ട് നാടക കല്യാണം എന്നൊരു പഴയ നാടൻ പാട്ടുണ്ട്, നാടകപ്പാട്ടുണ്ട്. അതുപോലെ ഒറ്റ വാക്കുകൊണ്ട് നമുക്ക് we can clearly say NYHA. Ordinary activity. Ordinary activity does not produce problem. 1. Ordinary activity produces problem. 2. Less than ordinary activity produces problem. 3. And 4 is the person cannot do anything without discomfort and may be dyspneic or symptomatic at rest. That is what is called as the NYHA. So he is in NYHA 2, according to you, right? Even after controlling all these symptoms, etc. Suppose he is still in class 2. Will you think of a surgery? That is my question. Suppose he comes back to you. അടുത്ത ആഴ്ച ഇവൻ തിരിച്ചു വരുന്നു. After 6 weeks of therapy and all, he comes back to you next week in your OPD, and the parents are saying that he is still uncomfortable on walking, and JVP is some 4 centimeter or 5 centimeter above the sternal angle, which means he is genuinely symptomatic. Maybe mild symptomatic, but symptomatic. Will you think of an intervention? And if so, intervention.
Try to control it medically maximally.
How will you medically maximally control heart failure?
diuretics and
diuretics. Okay, so you add diuretic. You will continue with enalapril. Will digoxin help in this patient? Yes or no? May not help. Actually,
may not
help because unless if there is a contraction problem, inotropy is reduced, then digoxin will be useful. Otherwise, it will not be useful. Now, Amal, what you should know is that nowadays, this rheumatic valvular heart disease, especially severe MR with symptoms, are offered a mitral valve repair nowadays. Because if you wait for a long period, what will happen is that the LV function can become affected. And once the LV function becomes low, the result of a mitral valve surgery is not very good on a long-term basis. So you should seriously think of a mitral valve repair, because there are very good centers in Kerala, even Kottayam. I think they have an excellent center where they're doing a mitral valve repair in both rheumatic and non-rheumatic MR and all. So you should seriously think. Then I will come back to the infective endocarditis prophylaxis. Now, Amal is absolutely correct when he says that according to the book, there is no need for infective endocarditis prophylaxis, because in 2007, American Heart Association guidelines said that there is no need for a valvular heart disease, either rheumatic or non-rheumatic. They did not mention, but they say. But there is a lot of controversy generated after this 2007 guideline. And I will tell you that around 80%, 80 to 90, or 70 to 80% of cardiologists, both pediatric as well as adult cardiologists, are still giving infective endocarditis prophylaxis in mitral valve disease, rheumatic mitral valve disease. So the practice in Kerala and in India is that you should give. So what you can do is, in the examination purpose, you can tell the examiner that according to the AHA guideline 2007, there is no need to give IE prophylaxis. But if Thrissur Medical College practices IE prophylaxis, we should tell that we practice this, because the examiners are also from India. Majority, they will give second infective endocarditis prophylaxis, right? Okay. Then I am worried.
They decided not to give prophylaxis.
What is that, Anand?
Why they decided not to give prophylaxis?
Now, what they said, and there was they said that two things were there. One is amoxicillin. They in UK, I think only one case of anaphylaxis due to oral amoxicillin, and they said that basically oral hygiene is more important. Continuing but oral hygiene is more important than giving a single dose of amoxicillin. So that is why they put the stress more on the passive infective endocarditis prophylaxis, like maintaining a good oral hygiene rather than IE. And they they stopped. In UK also they stopped. But after stopping, there was a slight increase in infective endocarditis in UK. But that was not enough to make the guideline makers to rethink about this. But general consensus among adult cardiologists and most of the pediatric cardiologists is that in India is that you should better continue IE prophylaxis for rheumatic valvular heart disease, because in Tamil Nadu and all, there are studies showing that 40% of infective endocarditis in young adults and youth are due to pre-existing rheumatic heart disease. I think rheumatic heart disease is a major substrate for infective endocarditis in our country. I think we should give. That is the general policy adopted. I think we should continue to do that. But Amal is right in saying that the guidelines are against it or not for it. So Amal, we will finish off. We'll have a conclusion. Anything else you want to say, Amal? Any questions to be asked? Any clarification on any point which we discussed?
Amal, stop video. Amal, if your presentation is over, you can stop video.
Okay.
Slide sharing. Stop.
See, Amal, one more thing I wanted to tell you. Amal was very correct in saying that, politically very correct when he said S1 is soft. So S1 softness is due to severe mitral regurgitation. There is no cooptation of mitral valve. That is very good. And he also said the wide split variable second sound, very classical finding of a severe MR, because A2 is earlier than P2. So there is a widening of split MR. That's very good. And we should have very carefully looked for an S3, but he did not get an S3. Murali?
Yes.
Good morning.
Good evening.
Good evening. Anyway, so that is the findings, sir. I think his findings S1 has to be defended, can be defended. S2, S3, you should specifically look for an S3 and a snap and a rub, of course, in this particular patient. And then evidence of PAH, I think there was no evidence of PAH. I think that is also acceptable. But, I think we should convey to them the need for continuing an lateral diuretic and rheumatic secondary prophylaxis.
The patient is put on digoxin, this patient.
Yeah.
Then that one will cause heart block.
Digoxin theoretically definitely it can produce first degree AV block. Second degree AV block is rather rare due to digoxin. So it is maybe a multiple factor may be operating in this particular patient. Maybe digoxin is also responsible. But anyway, now it has become an established, I suppose, no? 56 per minute and out. And another thing I wanted to say, I forgot, I think was that. Yeah, I think that is.
What is, sir, even though it's a teaching class, we'll ask 2-3 questions, sir.
Yes. Definitely.
So, what is Dr. Vijay is there, HOD Manjeri, Dr. Muralidharan sir, HOD Palakkad. So we got so many guests till at this 9:30 also, and a very good crowd. Now there are 77 participants.
Murli Palakkad, he's in Palakkad.
Yes. Very happy to see you.
Nice to see you, Murli.
Of course.
Anand,
So how you what is your now you are how many cases you are seeing rheumatic arthritis nowadays?
Yeah, rheumatic. Rheumatic. See what
new cases, not old cases.
Rheumatic fever cases. What is happening in that? I will say because I have spent 3 years in a corporate hospital, and before that I was in medical college. So before I retired for the previous 3 years, if you compare with the previous 3 years of KIMS, previous 3 years, the number of rheumatic fever in SAT was also low, something ranging from 10 to 12 per year, compared to around 20 to 30 Kawasaki disease admission. That was in SAT hospital. In KIMS hospital, I think 3 years I have seen only 3 or 4 rheumatic new cases. But I think what I know from Lakshmi, from SAT is that you have almost every month one case will be there, which will be around 10 to 12 cases per year for a new rheumatic fever. So there is always a what you call as a mal-representation of rheumatic fever in community in a private sector. So that is.
Dr. M. Sudha want to say some conversation message to sir.
Yeah.
Dr. M. Sudha.
Sudha, hello. How are you? Unmute ആകണം. Sudha Mash unmute ആകണം.
Okay, unmuted. Okay, nice to see all these veterans in pediatric cardiology and in pediatric.
Okay.
And I actually attended the entire session. The full compliment I had, and I take the opportunity to thank especially our guest, Professor Zulfikar. Okay, thank you. Good night, Anand also.
Dr. Vijay HOD Pediatrics from Manjeri Medical College, even though he is an endocrinologist, he is a very good clinician.
Good evening, sir. Good evening,
Hello.
Vijay Kumar, sir. It was a very, very good, very nice case presentation. And as you said, even in Calicut, last few years, number of rheumatic fevers are coming down.
Medical college.
Yeah. Even last, I think 2 years back, or around 8 or 10 cases per year.
Yeah.
It was much more, even 5 or 6 years back. As sir was telling, Kawasaki's disease is coming up. And the rheumatic heart disease is gradually coming down.
Definitely. So that is what happens is what happens is 10 years back in the 2000 era, we used to have late diagnosis of Kawasaki because we are not very much sensitized.
Yes,
but now I think the new generation of postgraduate may be less sensitized to rheumatic fever. There's a possibility that they may miss early presentation of rheumatic fever. That is always there. So in a way, this case presentation, in a way, it's good in the sense that you can have a very bad valve with rheumatic fever in Kerala also. And I was surprised to find that in Thrissur area, people took a lot of time. And when the child became class 4 only, the child was taken to the hospital. I think that is a very interesting situation in Kerala, to say the least.
We have last two comments from two Parvatis. One is VK Parvati Madam first, then Parvati Mohan.
Mohan,
VK Parvati Madam, VK Parvati Madam.
Madam?
Madam, Orangada Gati, MissIpur, welcome to the
Madam, unmute.
I say. Okay, it was nice hearing you.
Thank you, ma'am. A long time. IAP, physical interaction.
Then one question. I think this Amal didn't know about penicillin. No, that is only penicillin he hasn't heard. So can you just tell them which is better and whether it is to be given after food, before food, all those things? I think they, the present generation of PGs may not know that.
Okay.
Penicillin G and V.
Yeah.
Penicillin G and V.
Amal,
video.
That's okay, Amal. The point is that ideally we should give benzathine penicillin G, and the dose of benzathine penicillin G of children will vary. Vary means we will have two groups, as you said, above 27 kilograms and below 27 kilograms, which in the Western thing 60 pounds and all weight. So that is one. But generally, most of our medical colleges, including Trivandrum Medical College, we don't give benzathine penicillin. So we have the next choice is oral penicillin. Oral penicillin, we have phenoxymethyl penicillin, otherwise called penicillin V. And the other is a simple penicillin G, simple ordinary penicillin G made into a powder and made into a tablet. So the absorption, gastrointestinal absorption is very poor in penicillin G compared to penicillin V. And even you should know that penicillin V is inferior to injectable penicillin. So you are further diluting the efficacy of a penicillin by giving what you call as pendits. So if at all it is the penicillin V is not available, we give 400 milligram BD irrespective of the age. See, Amal, the most important point is the dose of both penicillin, both oral penicillin is same irrespective of the age. A 4-year-old child or a 40-year-old man or a 14-year-old adolescent will receive phenoxymethyl penicillin 250 milligram twice daily, and penicillin G will be 400 milligram, which is equivalent to 250 milligram of phenoxymethyl penicillin. As always try to get penicillin V, because I think there's a new manufacturing company which manufactures penicillin V nowadays for the last 1 or 2 years. So we have
potassium penicillin. That is phenoxymethyl.
No, potassium penicillin is the other one. It is the penicillin G.
There is some study from Padmavati and all. Sulfadiazine is better than penicillin B and other things. Sulfadiazine. But nobody using it. That's true.
Yeah, just we don't use it because of the fear of all the skin. Steven Johnson. Secondly, see, actually, the real what you call as the major study based on which we have been using all these penicillins for a secondary prophylaxis is one study called the Irvington House study. Irvington House was a sanatorium for a rheumatic fever, rheumatic heart disease patient in US. So that study showed efficacy or a recurrence rate. So recurrence rate for they used one phenoxymethyl penicillin, then they used benzathine penicillin, and then they used sulfadiazine. So when they used phenoxymethyl penicillin, they used 125 BD, that is the lower dose, and 250 milligram BD, that was the higher dose. So what happened was, the most efficient was benzathine penicillin, very efficient. Second was actually phenoxymethyl high dose and sulfadiazine, more or less same. And phenoxymethyl low dose was inferior to sulfadiazine. And so in that study, they showed that the phenoxymethyl high dose is same as sulfadiazine, but we are not using sulfadiazine mainly because of the adverse to us happening. That is the basic this thing. I think all postgraduate students of pediatrics should read something about this Rivington House study. There are so many studies. You should know the basic study on first primary and secondary prophylaxis. I think it will be very useful to you. Then you understand the logic behind secondary prophylaxis and primary prophylaxis.
Parvati Mohan, now she's working in Amala Medical College. Parvati?
Oh, hello. It was good to hear you discussing a case after such a long time. Reminded me of our days and SAT 30 years back.
Yeah, there was a time recently. Some of the postgraduate or a junior doctor told me, Parvati Madam. So I thought this Parvati Madam was VK Parvati Madam. Then they said no, Parvati Madam is our big boss and all. So I was amused. So then suddenly I realized that I have become very ancient, and we are all becoming ancient. How is Mohan, Vice Chancellor?
Oh, he's fine. He's fine.
So Amal is from your place, Kodungalur. Amal, basically you are from Kodungalur. So it was a wonderful session, and after 1 hour and 45 minutes, there is a still very good crowd. Thank you very much. Now I request Dr. Sajid Kumar, our secretary, to propose the official vote of thanks. Sajid.
Okay, thank you, sir. Thank you, sir, for inviting me. And thank you, Zulfikar, my own teacher. And it was a very great experience attending to the Zulfikar class once more. It was like a back to school experience for me, and this time in a very relaxed manner. So thank you, Zulfikar, for the wonderful session. So I also thank Dr.Amal for taking up this challenge, and you have done well. And also thank all the senior faculty also joined here.
Yeah, I honestly feel very honored, privileged to be, Parvati Madam. I mean, the senior Parvati Madam, because Pada Parvati is my close friend and colleague and all. So I think very happy to know that she's there. Madam ഉണ്ടല്ലേ മാഡത്തിന്റെ ഫൈനൽ ഇയറിൽ ഞാൻ മാഡത്തിന്റെ ഇവിടെ ആയിരുന്നു പീഡിയാട്രിക്സ് കുറച്ച് ഭാഗം മാഡം ഇവിടെ ഉണ്ടായിരുന്നപ്പോഴേ.
Okay, sir. Okay, sir. Sir, and all the senior faculty and all the PGs also joined here. So a big thank you from that, and also from the IAP Thrissur, whereas the Reddy Madam and Anand sir, and all the faculty from the GMC Thrissur. Oh, and also thank all the other faculties from the Amala and Jubilee also joined here. And also I'd like to remind that our next program is coming on February 25th. We have an infectious disease CME series coming up on every Thursdays. So it's a big event, and I hope all of you join on this event of IAP Thrissur. And see you on the next time, the next CME. And from good night from me, and Jai Hind and Jai Hind.